we have options available for increasing the chances for cure for patients with a high risk luminal early breast cancer, that is patients with 4+ nodes or 1 to 3 nodes, large tumors, grade 3, they would be eligible for Abemaciclib, 2 years of Abemaciclib based on the monarchE data, which showed a significant and clinically relevant improvement in IDFS and distant disease-free survival with an absolute benefit around 5% in both categories. And for patients with the germline BRCA mutation, we have similar risk criteria, either 4+ nodes, or if patients had neoadjuvant chemotherapy first, non-PCR, and a CPS-EG score of 3 and greater, they benefit from 1 year of Olaparib with improving their overall survival. So I think that times look very good for those high-risk early breast cancer. And what we have to do now is think about this in our tumor boards and also look at the germline BRCA testing in patients that would be candidates for Olaparib in the adjuvant setting. And then I think the only open question, and that's being internationally discussed, is what do we do in these very few patients with the germline BRCA mutation and the high-risk criteria fulfilling the monarchE inclusion criteria for Abemaciclib. And I think there the verdict internationally is still open. People seem to prefer Olaparib because it has an overall survival advantage. But I would argue in patients with a very high risk of recurrence, we could also do a sequential therapy, starting with Olaparib and adding Abemaciclib after that. As there were patients in the monarchE study with about 12 months out from their primary diagnosis. So, but that's an individual decision. Obviously, also depends on the reimbursement schema in the individual countries. But I think with Abemaciclib in those high-risk node-positive patients and Olaparib in the germline BRCA mutated high-risk luminal early breast cancers, we have very, very good options for our patients to increase their chances for cure.